back to the Journal of Oncology Practice podcast from ASCO. I'm Dr. Bob Miller, medical oncologist at Johns Hopkins and a consultant editor at the JOP. For this podcast, we're going to be hearing about a very interesting article in the September 2011 issue of JOP, which was part of the special State of Oncology Practice series entitled An Economic Assessment of the Association of Northern California Oncologists Member Practices. The background of this work is that ANCO and its executive director, Jose Gonzalez, in response to the economic challenges faced by its members in recent years, put together something pretty novel, which was a voluntary economic assessment service conducted by two nationally recognized experts in oncology practice management, Bobby Buell and Patty Falconer. I'm pleased to be able to speak with Mr. Gonzalez and Ms. Falconer, and I'll let them describe exactly what they did. By way of introduction, Jose Luis Gonzalez has been executive director of the Association of Northern California Oncologists, or ANCO, since 1993. He has been an association manager since 1982, previously with the Institute of Mathematical Statistics. Thanks for joining me tonight, Jose.
Thanks for having me, Bob.
Also with me is Patricia Falconer, who has been the president of Health Options since 1992. She provides practice management consulting services to hematology, medical oncology, and radiation oncology community-based practices. Welcome and thanks to you as well, Patty.
Thank you. It's a pleasure to be here.
So let me start by asking you, what was the economic and practice environment in Northern California like in 2009 that prompted ANCO to design and implement this consultation service for its members? And what was the intended audience?
Well, let me try and address that, Bob. In 2009, the association had approximately 400 physician members, and about half of those were in the community practice setting. Of note was that 60% of those community practices were single-site, relatively small practices. Mm-hmm. Now, we had become aware of the significant economic challenges that the practices were facing, as well as those presented by Medicare payment reform and its adoption by private third-party payers. But only a small contraction, a minor contraction of the medical oncology services had taken place in Northern California. Some member practices had moved from full-time medical oncology to half-time oncology and half-time internal medicine. A couple of practices had reduced physician staffing but remained full-time oncology practices. And one practice had transitioned from full-time oncology to full-time internal medicine. But early in 2009, a major event occurred. I almost, in retrospect, considered a seismic event since we're in California. And that was that a prominent, well-informed, well-managed medical oncology ANCO member, community-based practice, failed economically and closed.
I see.
Leaving the community without medical oncology services. Immediately occurred to me, was this a canary in the coal mine moment? Was this a sign of things to come for my other 60% of my membership? Or was this a sort of a one-off experience that were due to unknown to us internal management issues at the practice?
Let me ask Patty a little bit about the instrument that was used for this assessment. Maybe you could describe some of the economic parameters that you assessed and the methodology. And just tell me, did you have any previous experience with these parameters, or was there any type of independent validation?
Well, Bobby Buell and I developed a standard list of economic parameters that they were selected because they were applicable regardless of practice size, and if not performed correctly, were the most common cause of poor financial performance. We had experience with similar parameters for a prior project with ANCO in 2004 and in our private consulting businesses. And so we reviewed 7 economic parameters for each practice. First, we looked at gatekeeping, and by that we mean the practice of validating coverage for patient treatments and then providing financial counseling with the patient in advance of treatment. We looked at evaluation and management coding, drug purchasing, drug administration procedures, the practice's exposure or potential exposure to risk or of audit or potentially fraud, cash flow management issues, and participation in pay for performance programs.
So you mentioned in this in your paper, you mentioned that ANCO subsidized the practice participation in the assessment. Was this funded by a grant or was there some other mechanism?
No, the study was funded completely from ANCO funds. We did not seek a grant, partly in part because I did not have a readily identifiable source for such a grant, but secondly, because time was of the essence.
I see.
If this was a canary in the coal mine moment, we needed to get troops in the field assessing the practices as quickly as possible. We devised a fee schedule so that there'd be a $2,500 fee for the smallest practices, that's 1 to 3 physicians, a $5,000 fee for mid-sized practices of 4 to 10 physicians, and a $10,000 fee for the larger practices, 10 or more physicians. But we also told the volunteer practices, or the member practices, that ANCO would pay $2,500 of their fee. And that way we really thought we were targeting the very at-risk practices, the smallest practices.
So this was offered to all of the ANCO member practices then?
That's correct, Bob. Every member practice was solicited several times to encourage participation in the study. And the total expenditure from reserves to underwrite this project was almost $50,000.
How many practices ultimately signed up for this?
There were 14 total practices that enrolled for the consultation service.
So, Patty, tell me a little bit about the findings then. You had 14 practices, and you and Bobby Buell did this assessment. What were some of the principal things that you guys found?
Well, we obviously, the practices that chose to participate, many of them were having significant financial problems and would not have been able to access these kinds of consulting services without the help of ANCO. So what we found is that we were able to really make a very big difference for a lot of these practices, especially the smaller ones. In the area of gatekeeping, almost all of the practices that we assessed had some sort of financial counseling position performing at various levels of effectiveness. In small practices, the staff members usually do an inadequate job of patient screening and pre-collection activity, and that patient collection at the time of service was rarely done. However, the level of collection sophistication wasn't uniformly correlated with practice size. In fact, our experience was one of the small practices actually had the best gatekeeping practices
that's interesting.
Of all, which was very surprising.
Yeah.
Almost all the practices we visited seemed vague about payer coverage guidelines. Major third-party carriers all have published coverage policies that no practice seemed to use as a reference. The smallest practices often did not enforce Medicare's local coverage determinations, or LCDs. And with respect to ESA coverage, even one of the larger practices did not have adequate screening for the appropriate use of ESAs in chemotherapy-induced anemia. And that was also surprising.
So with the payer coverage policies, how readily available is this information? Is this something that you can just go on a website and look up, or is it sort of a Byzantine journey to find it?
Most of the payers have readily accessible coverage guidelines that can be viewed on their website, even printed and distributed amongst the practices. Some payers, it's a little more difficult to access, but it's there. You just have to look for it. And you also have to review it on an ongoing quarterly basis because the coverage guidelines change.
So it is there if you really wanted to find it. It's not something that's hidden somewhere or some proprietary thing where they're just not going to tell you what it is.
Correct. It is there.
This really sounds like some low-hanging fruit. I mean, look up the policy and just follow it, right?
Well, I think that the key is not how difficult it is to find the policy, but to actually use the policies in an effective way in the practice. And we'll talk about that a little later. But I think that's an opportunity for practices to do better.
Okay. So you give a list of some of the major impediments to cash flow. And one of the things that really struck me was that there were practices that had payments in arrears to the drug distributors. In fact, 4 of the 14 had actually had to suspend their operations of their infusion centers because they couldn't make their payments, which is pretty shocking, I thought. But do you think this is avoidable, or what was going on there?
Well, most of the cash flow issues were avoidable because they were caused by poor management decisions and ineffective billing and collection procedures. So if you think about the fact that practices have made decisions that then, as a result of those decisions, caused cash flow crunch, we found in order of importance that cash flow issues were really caused by the practice becoming in arrears to the drug distributors and thus incurring interest payments or balloon payments that were unexpected or unavoidable, the debt service to payments due to service expansion decisions by the practice and or building and substantial facility improvements, infrequent and or delayed claim submission by either in-house or outside billing services, lack of adherence to third-party coverage policies, poor collection of patient balances, and third-party payer delays. And the last really is coding inaccuracy. And all of these elements could be controlled internally to the practice.
Okay.
In terms of cash flow management, we looked at days from service outstanding, or DSO. The average days from service until claim payment, or DSO, was 44 days and ranged from a minimum of 23 days to a maximum of 87. Now, this compared unfavorably with the average DSO nationally of 40 days in 2009. And this was surprising because it was expected that ANCO member practices would have a DSO around 30 to 35 days, given that the participating practices had a patient population that was 51.5% on average Medicare. And we know that a submission of a clean Medicare claim should produce a payment within 14 days. On average, when we looked at accounts receivable, 20% of the accounts receivable for surveyed practices was over 90 days old. A minimum of 39% and a maximum of 84% of the accounts receivable that was older than 90 days was patient responsibility. Again, poor financial counseling, resulting in the inability to collect patient deductibles, co-payments, and co-insurance at the time of service, and the lack of adherence to medical coverage policies caused claims to be denied and were key contributors to the AR aging that would potentially result in bad debt.
How about the cost side of it? In Table 1, you talk about some variances in drug acquisition costs. How much of a problem was that?
On average, small practices paid 6% more than larger practices did for drugs. The average number of underwater, meaning drugs where the practice cost exceeded the Medicare allowable in Q4 of 2009, was 3. 4 of the 14 surveyed practices were in arrears to their drug distributor. 11 of the 14 did not regularly monitor drug cost versus reimbursement. We found that most practices used only one drug distributor and did not engage in competitive drug purchasing strategies. Payment terms that were defined as direct debit was used by half of the surveyed practices so as to achieve reduced drug costs. This payment term required the practice to pay drug invoices when the drug was shipped. Since the average DSO for each practice was 44 days, the practices found themselves having to finance drug costs for at least a month and a half before they received payment from the payers, and thus experienced strain on their cash flow and the potential for practice debt.
Okay.
When we looked at drug administration procedures, what we found is that in the small practices surveyed, only one practice drug administration services were unprofitable. The average drug administration cost divided by the average revenue for the small practices was 46%, and almost half of the small practices had infusion centers open less than full-time. In the large practices surveyed, the average drug administration cost divided by the average revenue was 73%, and all of the large practice infusion centers were open full-time.
How about E&M coding?
On average, the ANCO practices saw 242 new patients per physician per year, which compared unfavorably with 300 nationally. The number of office visits per physician per year was 3,186, which also compared unfavorably to the national average of 3,481. And we noticed that these statistics did not vary by the size of the practice. Now, we also saw that there was some coding differences to the national statistics, and that by and large, the ANCO physicians had a higher percentage of nursing visits, 99211, and higher level consults and high level hospital admissions than the national average. Concern for this is that these high than normal profiles could lead to audits by Medicare and other third party payers. And only 1 out of the 14 surveyed practices had educated their physicians about changes in coding for 2010, and many of the billers and coders had never been to an ANCO billing and coding professional education program. In regards to exposure to risk or audit, in addition to the profiles I just mentioned, several other areas of audit risk were identified around the coding for administration services. What we found is coding problems existed in the way that practices were determining initial, sequential, and concomitant infusion administration procedures, as well as IV start and flush codes. The last performance criteria was participation in pay for performance, and surprisingly, only 2 of the 14 surveyed practices participated in Medicare's e-prescribing initiative or other physician quality reporting initiatives. As a result of not participating, we estimated average loss of $39,500 per practice or $14,600 per physician.
Wow, that's quite a hit.
An avoidable hit.
So you talked about the accounts receivable being so high, up to 84% older than 90 days. Do you attribute that a lot to some of the issues you talked about earlier, like the gatekeeping problem? How much of that was unavoidable, do you think?
Well, I think that there are some market forces that certainly have made it much more difficult for our practices to deal with this issue. It used to be such a small component collecting from patients that you could not do it and still not suffer financially. But those days are gone. What we saw as a trend in 2009, which has continued into 10 and 11, is that patients have to pay more towards their healthcare costs than ever before. The percentage of covered workers with high deductible consumer-directed health plans, such as health savings accounts, increased from 10% in 2006 to 27% in 2010. And overall, we saw an individual's average deductible increase from $1,700 to over $2,000 per year. We also saw participants in Medicare HMOs increased in 2010 in all 58 California counties. And most of these plans require patients to pay a 20% copayment on every drug they receive. So practices face significant reimbursement risk now if they do not collect from the patient directly at the time of service. Effective gatekeeping procedures help to identify patients with significant out-of-pocket costs, and there are many types of patients now. And these include Medicare patients with no supplemental or secondary insurance, Medicare HMO patients who have 20% copay plans, consumer-directed health plans where patients have not met the deductible or out-of-pocket limits for that calendar year, patients with plans that have low annual limits, and patients that have plans with effective dates within 6 months of the first consultation that may be at risk for pre-existing condition limitations. And lastly, patients with drug regimens that include off-label drugs and or do not meet payer guidelines for reimbursement. So bottom line is practices need to establish stringent patient collection policies and help patients who cannot pay at the time of service to access patient assistance programs where applicable.
That's the data. You did this analysis for each practice, and then you made some recommendations. So what was the advice you gave to practices? Was it basically just get the earlier stuff right?
Well, we made recommendations to each participating practice, but we also made recommendation to ANCO for programs to support and assist their members. So Jose will address that after I do. But in terms of the practices, we recommended that oncology practices must increase the effectiveness of their financial gatekeeping procedures, that small practices needed to gain economies of scale and discounted drug pricing to be more profitable and survive. Physicians must use evaluation and management, procedure, and administration CPT codes more accurately, and that practices must continue to evaluate their costs of doing business, especially drug administration, and look for ways to reduce costs wherever possible. And lastly, practices should participate in pay-for-performance programs, starting with electronic prescribing and then moving to other physician quality initiatives.
How well received were these recommendations by the practices? If you told them they had to do e-prescribing, was there some recognition, or was that something that was just perceived as too much trouble and not worth the benefits?
Well, you can see by the percentage of practices that were participating in e-prescribing that it was so low that a lot of physician practices really found themselves unable to implement it, either because of staffing constraints, technology constraints, or just the bandwidth to implement a new program.
So, Jose, tell me a little bit about what types of things ANCO did differently, or what types of programs ANCO put in place as a result of this analysis.
The first thing we realized was that there was an immediate recommendation based on each of the metrics that the consultants had assessed. So we took as our recommendations that the State Society should offer member practices a financial counseling workshop that would include information on patient financial counseling, how to assess and follow coverage policies, remittance analysis, and how to collect payer and patient balances. Secondly, I took it as my charge to reintroduce the concept for board discussion of offering member practices access to group purchasing opportunities for drugs. Third, we should continue to offer physicians and practice staff coding education and access to coding assistance, either directly from the Society's office, through referral to expert consultants, or via ASCO's assistance program. Fourth, we should offer education and tools to enable practices to analyze their costs. An understanding of internal cost structures was key to being able to address when revenues weren't covering costs. And finally, we needed to offer education and tools to make it easier for member practices to participate in pay-for-performance programs such as e-prescribing, PQRI, at that time now PQRS, and other perhaps payer-initiated programs. We received the consultants' recommendations in about May of 2010. I felt these were such urgent needs that we designed a month-long series of webcasts entitled The Business of Oncology Practice, with an all-star national cast of characters to address many of these urgent issues. And many of those webcasts are still archived on our website for referral to member practices. The first, and these took place in October of 2010, the first 90-minute webcast was specifically on patient financial counseling and how to manage the cost of cancer care. The second had to do with reducing financial and reimbursement risk for chemotherapy and administration services, essentially talking about know what your coverage policies are and abide by them. Third, we focused on oncology coding for experts, specifically there also chemotherapy administration coding and E&M documentation. Fourth, we had an hour-long webcast on meaningful use, and it was humorously entitled No Cash for Clunkers. And finally, we invited someone to talk about oncology management trends, and that addressed the global concept of payer-provider partnerships and how to work with third-party payers in negotiating creative reimbursement arrangements to reward pathway compliance and quality care. We offered these webcasts to both ANCO members in Northern California and extended invitations to our Southern California colleagues as well, because we felt that it was likely that they had similar issues, even though they had not been specifically assessed.
Sure.
We had bumper audiences exceeding 90 participants at each of the webcasts.
And you said the webcasts are still archived now. Is that just for ANCO members, or can others access
No,
them?
our website is an open website, and anyone listening to our podcast today can go to www.anco-online.org and go to the education page and navigate your way towards the business of oncology webcasts.
Oh, that's great. Well, thanks for sharing that link. I want to talk to you a little bit about the follow-up interviews that you did. Another very interesting part of your paper was that you went back roughly a year later and you guys talked to, I think it was 12 of the 14 practices. What was their assessment of the survey process? And I guess more importantly, did they listen to you?
Well, there were basically two reasons why I came up with the idea and was encouraged to construct a follow-up assessment. Several of our board members wanted to know whether our investment had made any changes in the participating practices. Think of it as a physician prescribing a medicine. Did they adhere to their prescription? And secondly, we wanted to know what was their general reception of us doing this type of activity. So I went back to Patty and Bobby and said, would you all be interested in doing some sort of general canvassing of the participating practices to assess what they felt about the experience in general, but also to take their individualized recommendations and follow up. Did you do what we asked? If so, what have you perceived the effect to be? If not, why not? And I'll let Patty address what the findings were.
Well, in general, the participating practices were satisfied with the service provided. They mentioned they wouldn't make any major changes to the consultation provided other than maybe to broaden its scope or provide more face time with the consultants, that they would pay for the assessment in the future and found it to be a very productive activity. But in terms of implementing our recommendations, we found that at the time of the follow-up interview that the following was true. All participating practices were urged to increase the effectiveness of their financial gatekeeping procedures, and many had implemented significant changes in their practice to do that. We found that now the practices were conducting pre-service reviews, obtaining prior authorizations prior to treatment, and using and monitoring the websites for changes in coverage guidelines. These practices were counseling patients about the cost of their treatment, and they did not treat patients without insurance coverage. They were routinely collecting copayments at the time of service, assessing copay assistance programs when applicable, using internal systems to identify patients with payment difficulties, and meeting regularly to discuss claims, denials, and appeals. The second element that the economic assessment report urged practices to do was to try to gain economies of scale and obtain discounted drug pricing to be more profitable and survive. The interviewed practices were now actively analyzing drug costs versus expected reimbursement. Many practices, realizing that their drug pricing was poor, not only renegotiated their drug purchasing contracts, but changed their distributors altogether. All of the practices received recommendations to use CPT codes more accurately. Many of the practices have educated their physicians about correct E&M coding and specifically giving them tools to be able to do that. Many were providing coding education to the physicians and billers, and most importantly, conducting regularly scheduled periodic in-house chart audits. Some of those practices that did not have certified coders on staff have hired them. The economic assessment report also outlined that disappointingly few practices participated in Medicare e-prescribing and PQRS programs. But the practices now report at the time of the interview that they have systems in place so that their coders and billers return patient encounter forms back to the physician if no Medicare e-prescribe or PQRS codes are included. They also have started to investigate electronic health records and are implementing more of the features in their existing practice management systems or electronic health records. In general, many of the specific recommendations to the participating practices have been or are being implemented. The easiest and least costly of the recommendations, especially those pertaining to cash flow and coding correctly, were implemented most often. While no specific economic data was collected during the follow-up interviews, practices reported that some, if not all, short-term debt was retired and that cash flow had improved.
So it sounds like they really did listen to you.
Mostly.
They took most of their medicine.
Yeah, which is great.
So let me ask Jose, are you planning on offering this service in the future to ANCO members?
Well, as I mentioned, this service cost $50,000 to do, and the association doesn't necessarily have $50,000 to invest every year. But as economic conditions change or as other information comes to us and we find that it might be worthwhile to repeat the service, offer it to those who have not participated in the past, we may consider that. I'm especially interested in the potential findings of ASCO's upcoming survey of the membership entitled The Assessment of the Evolution and Status of Practices, or the ASOP survey. I'm in contact with ASCO. There's some hope that some regional data may be available to state societies. And if that data warrants it, then we might possibly be able to follow up with a replication of this or a modification of this particular assessment activity. But we're going to wait for the ASOP study to come out before making any determination on that course.
Jose and Patty, thank you very much for sharing your experience with us.
Thank you, Bob, for having us.
Yes, thank you.
And I want to remind everyone that this article is in the September JOP with the other great articles that were in the State of Oncology Practice series. It's available online, and your paper copy should be in your mailbox by the time you hear this. I also want to draw attention to some of the tables that were in the article, such as Table 1, which talks a lot about the variance in drug acquisition costs. I thought that was a very interesting part of ANCO's analysis. So please take a look at this issue for other thought-provoking original contributions and commentaries. I appreciate that you're listening to our podcasts, so please email us with your comments at jopeditorsdesk@asco.org or comment in iTunes. This is Dr. Bob Miller for the American Society of Clinical Oncology. Thanks very much for your attention.